Thank you, Nicola. So I'm Jatinder Harchowal. I'm the Chief Pharmacist at the Royal Marsden. I'm also the Medicines Optimisation Pathway Chair. And Anita McWhirter is my new models of care pharmacist who's supporting me in all of this work as well. So what I'm going to do is spend the next 10 to 15 minutes going through one of the projects that we've done in the last 18 months. But I really am going to be summarising 18 months of work that we've just been carrying out. And this started in May 16, and in the spirit of working together across the vanguard, the three chief pharmacists from the Christie, UCLH and myself had met and looked at trying to create a new medicines optimization pathway that was going to start and do some new and innovative projects around the country. And we started with a novel approach because we were getting asked by the pharmaceutical industry, who were very keen to engage with the vanguard, but also support us on a medicines perspective. And so we did what's now been well known and called the Pharma Challenge, where we turned it on its head and went back to the industry and said, actually, if you'd like to work with us through the vanguard, here's an outline of some of the work that we'd like to do. Come to us with some project ideas. And we were inundated in a month. We had 40 projects that were put forward by the industry. And so the three chief pharmacists, together with clinicians, nursing staff, some patient groups and pharmacists and nursing, met and reviewed all of these projects. And we chose 6 projects. And the 6 projects were led by either the Marsden or by UCLH or the Christie, but under the whole medicines optimization framework. We set up a monthly governance group where we chaired oversight of these particular projects. And if you look back on what we've achieved with those, UCLH led on a big project looking at out-of-hospital administration of chemotherapy and looking at models, and that's now been published. The Christie looked at unwarranted variation for metastatic colorectal disease patients and developed an app which was to allow patient-reported outcomes to be fed back to clinicians. And all of these were going to be piloted in their site, but going to be available across the whole country. And what we led from the RM partner side was the introduction of biosimilars in oncology. And that piece of work I'm going to go through now. And the reason why we chose biosimilars was that Sandoz approached us in a non-promotional way to want to work with us to try and introduce biosimilars into the oncology market, knowing that previous biosimilars that had come into the NHS had a really poor and inconsistent uptake. If you look at how well they were taken up by hospitals, it was really mixed. There was a potential to save a huge amount of money for the NHS without compromising patient safety. But we realized we had to do something different. But what we wanted to achieve was to have a set of material in a centralized repository that was going to be available for the whole country to try and introduce biosimilars into oncology. And this is what we did. So we actually produced a website which hosts all of the material that any organization would need for the safe introduction of a biosimilar. And in this case, it was biosimilar rituximab, which we knew was used in rheumatology in small amounts, but a majority of it was used in our lymphoma patients. And what we wanted to do was get the experts together from around the country, but try and produce a series of information that anybody could get access to from here. And so even though there's lots of little tabs here, you could click on any one of these. So if I clicked on, let's say, commence staff education, you could click on that, and it would take you straight to a checklist of what you would need to introduce in your organization to have biosimilars taken up. And actually, if you look on the right-hand side of this, this is a biosimilar educational deck. We even produced a series of slides that any organization could introduce in their trusts. And if you click onto that, it would take you how biologics are manufactured, how biosimilars are produced, explaining the licensing requirements, but most importantly, allowing people to get a better understanding about what biosimilars are. And the click of any button here will take you back to your website. We also then made sure we had patient groups involved. So if you see there, if I tick onto here, it will show you the engaging patient and patient groups. We really paid attention to having patients involved in the uptake of biosimilars. And that way we involved the Lymphoma Association, and we produced, if you click on that here, you'll see on the right-hand side a series of information that was co-produced from the Vanguard with the key patient groups. So if you click on the Lymphoma Association, you will see an information leaflet that was allowing anyone to ask any questions and answers about biosimilars. And this was critical to get the patient group buy-in, because the basis that we used for all of this was to say, if people understand about how biosimilars are made, you've got patient acceptance, and you've created protocols and hopefully policy guidance, then that would allow people to take up biosimilars a lot quicker and a bit more consistently around the country. But we wanted it available anywhere. So at a click of any button, you get access to all that information. The interesting thing here was that when we produced this, we didn't really know how widely it will be taken up. And this map, we tracked everybody who accessed the website and downloaded information. And I hope you can see the figures here. The first thing to highlight is this was the end of October, this data is, and since then it's gone up by another 1,000. So nearly 4,500 hits on the website, information downloaded from around the country. But as you can see, we never expected it to have this breadth of access. So around the world, people have been actually downloading this information. It isn't me going on my holidays and downloading, in case you're asking. It was genuinely people as far as Australia and New Zealand who are using this information. And this highlights a really important aspect, was that we felt through the Vanguard we wanted to exploit the scale, the expertise, but also try and do everything just once, and the rest of the NHS then can hopefully use the same information. There is a real challenge, I think, whenever you try and introduce something where people are often developing their own version of information leaflets or an approach, and we try to lead all the country, and not just country, but across Europe as well, to use the same information. And interestingly, that's what people have been doing in downloading. So what's the results? What have the results been on this? Well, the first thing to highlight is as soon as the biosimilar rituximab became available, two of the Vanguard sites, so UCL and the Marsden, did a complete switch over. We collected data on every patient that was on the original rituximab beforehand, and this was safety data and time on a day unit, and then we recollected all that data once it was switched to a biosimilar rituximab. And we had data collected to the end of September, which showed nearly 800 infusions had been administered. The reactions from a safety perspective were completely in line with what you'd see with the originator drug, mainly grade 1, grade 2. That data has been presented back at the American Society of Hematologists in December. We've got more complete data, and UCL kindly presented that for us. But the other key thing was really what was the impact of all of this. Now, when I tell you the previous biosimilars, which are infliximab, etanercept, it took probably 12 to 18 months to get close to 50% uptake. And in 3 months from having the biosimilar available, all the biosimilars available, the national uptake figure by the end of November was 65% uptake of the biosimilar. In London, that figure was 85%. Now, why is that such a big thing? Well, actually, when you look at the pricing of the biosimilars, they've now come to almost half the price of what you do with the originator product. So the national saving just on a 65% uptake at the moment is £60 million. And that's likely to rise close to 90 to 100 million. Now, unfortunately, we don't get any of that money, Nicola, do we? Unfortunately, it goes to NHS England, but it's making a significant efficiency. The other key thing we did was help inform the commissioning guidance for the country as to how you introduce the best value biologics, and that was released by Simon Stevens in September. But we've now been asked by NHS Specialised Commissioning for the Cancer Vanguard to lead on the future introduction of biosimilars. So the next one to come to the market is biosimilar trastuzumab, Herceptin, and that should be available in the next 5 months. And again, we'll be leading that for the whole country. So really what we managed to create here, I think when we originally came up with the project, we had hoped to have got this scale of uptake and hopefully best practice spread around the country, but we hadn't quite anticipated that it would happen at this pace. So that's been really, really pleasing. So that's the project we've led on. But what are we going to do going forward? And one thing Nicola wanted me to do is just talk a little bit about our plans for the next year, utilising what we've learned from here. So the 3 things that we're going to really focus on now, and Anita's going to be leading this with me throughout the next 12 months, is first of all to develop even more care close to home. So one thing we recognise across RM partners is the increased capacity that's causing problems in every single unit. So we're now going to be exploring a partnership with either a third-party provider or through individual organisations to provide either community pharmacy or health centre administration of low-risk medicines. Take out some of the care that doesn't need to be delivered in some of the hospitals and releasing some of that capacity. We've got Two that we're going to start with, which is your subcutaneous trastuzumabs and denosumabs. But the idea here is to get a sense across our own partners as to how much that would release, both in terms of capacity, but also the savings that would make as well. And no doubt, the economies of scale by working with a third-party provider and developing these models makes a lot of sense. So we are now restarting a new medicines optimization group, which will have representatives from all the sites of our own partners, and this will be one of the work streams that we're going to be looking at. The second thing we're going to look at, which is actually not just across our own partners, but across the whole of London, is standardising the chemotherapy treatment protocols. So we started this work years ago with the previous LCA. That had paused somewhat in the last 2 years, but there was a huge amount of value to try and make sure that everyone's got the best practice pathways, but also you standardise the treatments that are being used across every chemotherapy protocol. And that's going to be a big piece of work. We have the first meeting set up, I think, in the next 4 weeks, and all of the organisations from our partners are part of that, and we will share the work out, but ensure there's consistency in what we use, not just for our chemotherapy pathways, but also all of the supportive treatments. And that in itself brings a lot of efficiencies. It stops everybody having to rewrite their own protocols. So implementation of best practice guidance across all organisations will feature highly for us in the next year. I can't do a talk without mentioning biosimilars again. So the next biosimilars, as I've mentioned, is going to be trastuzumab. The thing to bear in mind here is there's a £57 million spend on the IV formulation of trastuzumab. And actually, we can probably halve that if we look to adopt the best practice again. Again, doing that in a very quick period of time. But importantly, we're also working a lot earlier with the patient groups. So Breast Cancer Care and Breast Cancer Now are going to help us produce information leaflets. So again, the patient uptake and very active groups need to be central to whatever we're trying to do in this. So that's going to be good. And then the final one is looking at engagement with community pharmacists. So you're 6 times more likely to visit a community pharmacist than you are a GP. And so how do we support some of the other work streams that you've heard about this morning? Well, one of the things we're going to be looking at is how do we support the lung cancer pathway group and trying to get community pharmacists trained and try and get them to start referring via their GPs for those people who might be at greatest risk of developing lung cancer. So getting that earlier diagnosis agenda really high on a community pharmacist workload. And some of that supporting smoking cessation, so we're going to do particular work with them. But really it's about saying, actually, how can you try and get them engaged as part of the overall treatment plan? So I'm going to stop there. And what I'll be happy to do is take any questions on either the biosimilars work that we've achieved or any of the pathway work that we're going to do for the next 12 months. Thank you very much.